Welcome, everyone, and so glad to have you all here joining us on Forum Live. Today, we are joined by some esteemed guests, and we're just delighted that you're able to join us for this presentation. I am Dr. Grace Wright, and I will serve as the chair for this program. I'm a consultant rheumatologist in New York City, in the state of New York in the United States, and also president of the Association of Women in Rheumatology. I will be joined live by Professor Ernest Choi, who's director of the Cardiff Regional Experimental Arthritis Treatment and Evaluation, or CREATE Center in Cardiff, Wales, in the UK, and Professor Jeffrey Curtis, who's professor of medicine in the Division of Clinical Immunology and Rheumatology at the University of Alabama, Birmingham, here in the United States. So really pleased to have them joining us. And just sharing our disclosures here, giving you a brief second to see mine, Dr. Choi and Dr. Curtis. We'll see this again during the presentation. So just as a reminder that all attendees will be on mute for the duration of the meeting. Questions to the speakers can be submitted at any time throughout the Q&A function. We will address the questions and try to answer them as we go, but really at the end of each segment of the webinar. If you have any questions or any technical difficulties, please feel free to use the chat box for that. But any questions that you wish to have answered, submit that through the Q&A. So again, thank you, my dear colleagues and friends, Ernest Choi and Jeffrey Curtis, for joining us here today. Thanks so much for being here. So we are now just going to give you the outline of the program. The welcome introduction I am actually already doing, but we will then follow that with a talk on precision medicine in rheumatoid arthritis, led by Professor Choi, followed by precision medicine for rheumatoid arthritis patients by Professor Curtis. And then we'll have a discussion in which we'll be able to answer any remaining questions that are burning and summarize and close and really then give you the highlights for our next session. So we're going to start off now with Professor Choi, just to give you a brief introduction to my dear friend Ernest Choi. Professor Choi is the director of the Cardiff Regional Experimental Arthritis Treatment and Evaluation Center, or CREATE, in the Cardiff, UK. He has a major research interest in experimental medicine and clinical trial design in rheumatic diseases. His work is focused on immunopathogenesis of inflammatory arthritis to develop more targeted therapy and personalized treatment. Professor Choi has served as chief investigator of many clinical trials, and he has also conducted several proof of concept, first in human clinical trials in inflammatory arthritis, especially rheumatoid arthritis. He's also interested in improving the assessment of disease by developing better outcome measures, and he has served as chair to a number of working groups in the Outcome Measures for Rheumatology Organization, or OMERAT. So it's with my greatest pleasure to welcome you to the stage. Thank you, Ernest.
Thank you for that very, very kind introduction, Grace. And it's my pleasure to share this faculty with you and Jeff to discuss a topic that is close to my heart, precision medicine in rheumatoid arthritis. And I would, first of all, give you a bit of history, detailing some of the biology that underpins what we are talking today. And that will segue into Jeff's talk about how to apply it in everyday practice. So these are my disclosures. So this is the front cover of Nature Outlook in 2018, and it declares that it expects the next decade will be a decade about precision medicine. And the reason for that declaration is underpinned by what is shown on the bottom left-hand side of this slide. You will see the word Illumina. So Illumina is a next-generation sequencing technology that allows us to enter into an era of medicine that we call non-hypothesis research. The technology allows us to transcribe every gene, every protein, and this multi-omic approach, not relying on exploring one single hypothesis is thought to able to allow us to really deep dive into delivering precision medicine. Now, the term precision medicine is linked to rheumatology. So on the right-hand side is Sir Archibald Garrett, who is widely regarded as the father of precision medicine because he's the first rheumatologist who identified the genetic basis of rheumatic diseases such as alkaptouria. Of course, that is related to the presence of certain metabolite that one can detect in the urine. Now, on the left-hand side of this slide is the father of Sir Archibald Garrett, Sir Alfred Baring Garrett. He is the person who gave the name rheumatoid arthritis to the disease that we are discussing today. And if you notice the story that underpin why he decided to call this disease rheumatoid arthritis is that in 1890s, he noticed that in patients with chronic inflammatory arthritis, if you leave a piece of string in the urine of patients overnight, many patients will have deposits of crystals. But he also noticed that many patients did not have crystals in the urine, and that led him to hypothesize that in many patients, the disease is caused by a toxin that causes crystal, but there must be a condition in which the toxin is not detectable in the urine as crystal. And he named this disease rheumatoid arthritis. So now, these days, as rheumatologists, we are almost spoiled for choice. We have many treatments for rheumatoid arthritis. I've only listed advanced therapy here, be it the anti-cytokine therapy like anti-TNF, anti-IL-6, the anti-lymphocyte therapy, as well as the JAK inhibitors. But you will notice in many guidelines, there's no definitive guide on which patients to use which treatment. Now, research there's always been a desire for outcome research to come up with a predictive biomarker that will tell us which patient to respond to which treatment, although with limited success. At least what we know is that in patients, their rheumatoid factor and anti-CCP status is associated with the magnitude of response to rituximab. So patients who are seropositive are slightly more likely to respond to rituximab. But you will also notice that patients who are negative either for rheumatoid factor or anti-CCP antibody have a slightly less likelihood of responding to rituximab, but the percentage is still substantial, 45% and 55% in the RABBIT registry. And similar to rituximab, there is association between seropositivity and response to abatacept, as shown by this action study here. But again, whilst this can be useful as a guide, this has not translated to everyday practice into guidelines to say that patients who are seronegative should not be treated with these agents. So they're relatively helpful, but not absolutely helpful. What we do know is the seropositivity is not related to response to TNF inhibitor. So this is a systematic review and meta-analysis to show that unlike the anti-lymphocyte treatments, anti-TNF response is not associated with seropositivity to anti-CCP status. So it gives some rationale to say that rheumatoid arthritis is heterogeneous and patients who are seropositive are different from patients who are seronegative, and they perhaps are more or less likely to respond to different class of treatment. Although this does not absolutely help us to guide our treatment decision in everyday practice. Now we know that the situation is a lot more complex. And one of the first studies that show us this is the PEAK study. So this is a study in the UK, conducted in the UK and in Europe. It used fine needle arthroscopy performed at the time of diagnosis of rheumatoid arthritis. And you can see that close to 150 patients at the time of diagnosis, before they were started on any conventional DMARDs, were enrolled into this study. And what was clear by just looking at the histology of these patients with just diagnosed rheumatoid arthritis is that the histology are very different. You can see there's different pattern of inflammation in the joint. In some joint that are dominated by monocytes, others are dominated by lymphocytes. And in fact, in some patients, there's a paucity of immune cells. So although these patients have the same diagnosis as rheumatoid arthritis, the underlying pathology seems to be dramatically different. Now, with the technology that I mentioned to you before, it is possible to transcribe all the genes that are being expressed in the synovium. And interestingly, these kind of technology allow us to see that, in fact, the different pattern of cellular infiltration in the synovial tissue is mapped to certain gene expression, showing that, in fact, the cells histology are not only different, but these cells have very different activity in the synovial tissue. Now, with modern day bioinformatics, we have extensive knowledge about what cells transcribe what genes, and you can map the gene expression in the synovial tissue with the known biology of the cell type, and finally define what you will be expecting to happen in this synovial tissue. And if you do this kind of modern bioinformatic analysis, you can relate to the histological feature, to the genes that are expressed by different cells, and you can actually see in the individual patients which cell types are dominantly being active in that synovial tissue. And in fact, these allow us to look at different clinical characteristics. On the left-hand side, patients who are positive with ACPA versus patients who are negative. So genes that are expressed by patients who are seropositive are shown in blue. So these are on the vertical axis, log increases in the gene expression. And the further it is towards the right, with bias towards patients who are positive towards rheumatoid ACPA. On the left would be a reduced likelihood of these genes being associated with the presence of ACPA antibody. And you can do the same looking at patients who are likely to have progressive or non-progressive radiographic damage, and you can identify specific groups of genes that are associated with progressive versus non-progressive disease. So the genes can be mapped to individual clinical features. And in fact, in this study, it shows that the additional value of this genetic signature over the known predictor of disease progression, such as baseline X-ray score, seropositivity status, and it shows that if you added in certain gene value, you can add to the predictive value of how likely this individual will have progressive disease. And last but not least, in this study, they followed the patient after they have been started on methotrexate treatment and show that, in fact, the different pathotype at the time of diagnosis was associated with different response to methotrexate. For example, in the patients who have palsy immune pathotype, they are the least likely to respond to methotrexate. So what this study is telling us is this: rheumatoid arthritis, despite we have a fairly common diagnostic criteria, is actually a very heterogeneous disease right from the time of diagnosis. Even though the clinical features may have been common, the underlying pathobiology are different. They're driven by different cell type, and as a result, with the different genes that are expressed by the synovium, we would expect there are different cytokine, chemokine, and biologic molecule that drive both inflammation and joint damage. Hence, not surprisingly, we don't see a universal panacea for rheumatoid arthritis. There is no treatment that is universally effective in every single patient with rheumatoid arthritis. Now, that is the nature of rheumatoid arthritis. And in fact, it suggested that the disease probably started many years before the disease onset. And by the time we make the diagnosis, we have an organized, individually different immune response. Next, I'm going to show you the environmental influence that may impact on the biology of rheumatoid arthritis. So here are two studies. The first published in Genomic Medicine. It looks at the microbiota in the gut in patients with rheumatoid arthritis. And it took patients who both respond to or non-response to conventional synthetic disease-modifying drug and look at the microbiota. And by looking at the microbiota, it found that perhaps patients who respond to treatment have very different microbiota than patients who are refractory to conventional synthetic DMARDs. And what they also look at is what is the additional value of this microbiota, and using modern machine learning technique, it tried to examine whether the presence of certain bacteria will add to value of the known predictor of response to conventional therapy. And what it shows is that perhaps the presence of certain type of bacteria is good, and it can help to predict whether the patient will respond to treatment. Now, it's important to note that the size of this study is fairly small. That's just about 30 patients, including in this study, so not a large study. Now, a separate different study also looked at the microbiota and also tried to look at whether microbiota in patients with rheumatoid arthritis would predict response to methotrexate. Now, in this study, they come to slightly different observation in the sense that different groups of bacteria were associated with either response or non-response to methotrexate. But one thing that this study adds to the last study is that it not only examined the nature of the bacteria, but it also looked at the metabolic activity of these bacteria. And in examining the metabolome of these bacteria, it concluded that not only the species is important, but the metabolic activity, what these bacteria are doing, seems to add to the predictive value in whether the patient will respond to methotrexate or not. And he suggested that perhaps the microbiota can act as a predictor of response to methotrexate in new onset rheumatoid arthritis. So that is the interaction between environment and perhaps the nature of the disease. Now, ultimately, many people would think that synovial biopsy or examining of the microbiota are very complicated, and every rheumatologist I know would love to just able to do a blood test in order to predict a response to treatment. And in the next part of my talk, I will review for you some of the work related to this area, highlighting that perhaps the answer is not so easy. So first of all, This is a study that tried to look at, first of all, the synovial pathotype, again, in patients with rheumatoid arthritis, and looking at different kind of pathotype genes that you may be associated with different pathotype. And in this study, what they then look at is, are there characteristic genes that are associated with certain pathotype, and whether we can just measure this specific genes in the blood and therefore related the response to treatment. And using this strategy, it suggested that perhaps in the myeloid phenotype of rheumatoid arthritis, there's a high expression of soluble ICAM1, which is shown in blue, while in a lymphoid-dominated pathotype, there's a domination of CXCL13, and they show in a head-to-head comparison study between adalimumab and tocilizumab that patients who have a high expression of CXCL13 in the blood are more likely to respond to tocilizumab, and patients who have a high level of soluble ICAM1 are more likely to respond to adalimumab, as just by the ACR50 response at week 24. So that was an encouragement. Perhaps if we look inside the joint, we may be able to identify biomarker in the blood. But when we look at this more systematically using the peak phenotype, these detailed analysis in cell report highlighted some of the methodological challenge. So these are 3D volcano plots of all the genes that are present in panel A in the joint and in panel B in the blood, and they're pair samples. So when the patient have a synovial biopsy, at the same time, they took a blood sample in the blood and they tried to map the genes that are present in the joint in panel A with panel B. What you'll notice, first of all, is that the axis of these 3D volcano plots are dramatically different. So the y-axis of these 3D volcano plots are log graphs. So you can see that in panel A, the expression of genes are several thousand-fold higher in the joint compared with in the blood. And you can see also the shape you see in the joint is dramatically different from the blood. And I guess these days, this should not be a surprise, because what we have learned from COVID-19 infection is that, in fact, inflammation needs to be contained within a certain site. If we allow inflammation to leak out into the systemic circulation, inflammation can be extremely damaging. But it highlights the challenge, just because a molecule may be highly important in the joint, we may not be able to find a signature of that in the peripheral blood. Now, going into a more deep dive analysis, is possible to try to identify potential genes that you have identified in the joint and try to look for these specifically in the blood. And this is analysis done on the right-hand side of this slide, and all the genes that you have picked up that may have the potential to predict certain response shown in purple. So you can see that actually, if you look at something like 500,000 genes that you can find in the joint, there are only very few genes that you have a chance to able to pick them up in the peripheral blood. So that adds to the challenge of thinking that we were able to generate a single marker that will help us to predict response to treatment. So going back to the last part of this talk, based on what we know, the hypothesis that in fact rheumatoid arthritis is a heterogeneous disease and the pathology in the joint may predict response to treatment, the Alpha-RA study is a randomized controlled trial that looked to see whether the pathotype in the joint can predict response to treatment. So it took patients with rheumatoid arthritis who have failed a TNF inhibitor. And then every patient had a synovial biopsy. And they classified patient as having lots of B cells in the joint versus synovial tissue that is poor in B cell. And it hypothesized that in patients in which the disease is not driven by B cells, therefore B cell poor, they would not have a very good response to rituximab, and they may well have a better response to tocilizumab. And in fact, this study concluded that this was indeed the case. So in patients who are B cell poor at the beginning, either classified by histological classification or RNA sequencing, CDAI response of more than 50% were higher with tocilizumab than rituximab. If we switch to look at patients in whom there are lots of B cell in the synovial tissue, there were no difference in clinical response to tocilizumab versus rituximab. So it suggests that the biology in the synovium has clinical meaningful predictive value. So a few weeks ago, these paper published in Nature Medicine based on the gene expression in the synovial tissue. Now, based on what I told you before, there were groups of genes present in the synovium, and there's hard to find one or a few marker of the biologic activity in the joint. In this analysis, they use machine learning to cluster the genes and try to ask the question, can machine learning or artificial intelligence help to pick up a group of genes that will help to predict either response to rituximab or tocilizumab? And the answer is shown in panel B. What these models shows is that there are certain groups of genes that is associated with response either to rituximab or tocilizumab. And in fact, by using these genes, they were able to have an area under the curve of more than 80% in picking up response to treatment to either rituximab or tocilizumab. So this shows that potentially this may well be the future. We may not be able to come up with a single biomarker of response to treatment, but computational modeling may well come up with groups of genes that help us to predict response to treatment. So ultimately, what we need to see in the next phase is a complete change in our thinking about how we design clinical trials. The R for RA is what we know as a biomarker stratified randomized control trial. But in the fullness of time, if we want to deliver precision medicine, we need to change in more precision trial design, either using umbrella design trial or basket trial, trying to use biomarker to predict not only response to treatment in a single inflammatory condition, but potentially grouping different inflammatory conditions together and use molecular analysis as a tool to allocate and stratify treatment decisions. So with that, I'll conclude by saying that the precision medicine aims to deliver tailored treatment for individual patients. And what we know is that in rheumatoid arthritis, the disease is diverse with different synovial pathotype and their associated response to treatment. And we know that the biology of rheumatoid arthritis can be influenced by environmental factors such as the microbiota in the gut. And in the future, we are likely to be able to employ multi-omic approaches in trying to work out whether the patient will respond to which treatment. And with that, I'm happy to answer any treatment that you may have. Thank you very much for your attention.
Thank you so much, Professor Choi, for this really sort of fascinating dive into all of the components of what we consider to be the patient. So I have two related questions from the same speaker. I'll put them out and then just throw another one. Coming from Peter, the question is, how does the presence of multiple RA phenotypes match the that the microbiota would be a predictor for the response to methotrexate. Do the bacteria override the effects of the patient phenotype? And the run-on to that is, in addition to this, does this suggest that the effect of methotrexate, in addition to what it does for the disease itself, has an impact on the microbiota, creating a better balance within the microbiome?
Well, that is a really, really great question. So I think one thing we are reasonably sure across many chronic inflammatory diseases, not only rheumatoid arthritis, is that there are certain microbiota that is pro-inflammatory, and there are certain microbiota that are anti-inflammatory. And you can take different approaches to it. It doesn't look as if we can use the exact genre to predict what the overall biology will be like. It is more likely that, we will have to look at the function and metabolism of this microbiota to look at what is biology would be. And you can take different approaches to it. You can say that by understanding the metabolic pathway where this microbiota either mediate pro or anti-inflammatory diseases, you can use it to develop new treatment and new pathway to influence inflammation. Alternatively, the microbiota can be changed. We can change our diet easily. So we can try to modify our diet to make it into a more anti-inflammatory environment. So, I think the microbiota is clearly important in modulating the immune response. Exactly how we want to use the information and data is something that we cannot be absolutely sure of, but has lots of potentials.
Absolutely. And we see in practice every day, patients coming in with, multiple page printouts of their gut analysis, and they want to know what to do with it, how will what can they do to change their outcomes? And so very interesting to see this interchange. And then we just had this recent presentation at ULAR looking at methotrexate and its use to delay the onset of rheumatoid arthritis in patients with arthralgia, and wondering at what point is this working, right? Is this working solely on the gut? Is this working on a disease that is not yet fully expressed? We don't have pathotypes because that's not who we've studied in any of these analyses. Any thoughts on that from either you or Jeff, if you want to jump in, any quick thoughts on that?
My personal take, and Jeff may disagree, is that what the effect of methotrexate seems to do is to delay the development of arthritis. It doesn't strike me that it will stop the rheumatoid arthritis. What it does is delay it. And I don't know for sure we know how it works in terms of how it delays rheumatoid arthritis, be it just masking the level of inflammation. There are interesting hypotheses. So, for example, increasingly we think of development of rheumatoid arthritis a little bit like cancer. It's a multi-step process. So you develop a propensity abnormality in your immune system. And I think there's some evidence that with repeated insult and inflammation, you ramp up your immune response until the tolerance is broken and you get full-blown manifestation. And maybe methotrexate is able to reduce that progression of multiple impulses, but working out exactly how it works and whether there are more targeted treatment that are more effective would be something that we need to examine in the future.
For sure. Well, thank you so much. Jeff is going to actually talk about this from the patient perspective. So let's go ahead and share his slides. Thank you so much, Ernest, for that really fascinating dive into an area that is really sort of very important for so many of us. So let me just introduce again my friend and colleague, Dr. Jeffrey Curtis. Professor Curtis is a rheumatologist and epidemiologist and a professor of medicine in the Division of Clinical Immunology and Rheumatology at the University of Alabama at Birmingham. His research interest is focused on the efficacy, comparative effectiveness, and safety of the medications used to treat rheumatoid arthritis. And he is a co-PI of the PCORI-funded patient-powered research network Arthritis Power Registry, focused on RA, psoriasis, and psoriatic arthritis. He also leads the multi-center NIH-funded Large Pragmatic Randomized Controlled Trial, or VERV, studying the safety and effectiveness of the live herpes zoster vaccine in patients receiving biologic agents. He's a member of the Center for Disease Control Advisory Committee on Immunization Practices, the herpes zoster work group. And in 2015, he was appointed as a member to the FDA Arthritis Advisory Committee. So Dr. Curtis, I welcome you to your presentation. Again, please post your questions into the Q&A and we will have a nice discussion afterwards. Jeff, thank you.
Well, thank you so much. I greatly appreciate the invitation to be able to be with you today, albeit virtually. And Professor Choi gave a great background and some really provocative data on how we can do better achieving personalized medicine and precision medicine for rheumatoid arthritis patients. You might consider that this is the second half of that talk, and hopefully I'll bring you some practical aspects that might be useful. This is the full citations of a couple of the publications and abstracts that I'm going to talk about in the course of the discussion today. Let me first ground us to make sure that we're all talking about the same thing. And this is among my favorite quotes. Of course, this is the famous Danish physicist Niels Bohr, who taught us a great deal and won the Nobel Prize about the structure of the atom. So he's attributed with saying prediction is very difficult, especially when it's about the future. And the reason that I bring that up is to remind you that both from his perspective and certainly from a statistical perspective, we want to predict the future. And in fact, as clinicians, we do that each and every day. You do it informally. When you make a decision about what therapy that you're going to start for this patient, you're basically predicting what the future might hold for her if you take this course of action rather than a different course of action. We would like that to be evidence-based. We'd like it to be data-driven, but so often it's not, and we're, extrapolating or frankly, we're just guessing or doing what insurance companies or payers tell us. But in all of the things that we're going to talk about, we want to know what's going to happen in the future at the time that we need to make a decision. And so we're not going to talk about correlations. We're not going to talk about associations. We're going to talk about, I need to make a decision now so that in 12 or 24 weeks, I have an accurate sense of what probably will happen for this patient. Obviously relevant for very much in clinical medicine. For literature fans, Mark Twain has been attributed to say this, and then for baseball fans, Yogi Berra, likewise. And of course, a data-driven approach to selecting first baseball players, and then in the world of sports analytics has revolutionized lots of different aspects, not just medicine, and modern machine learning techniques have really done a lot for us, and we'll talk about that. So let me remind you something you probably already know, but that is to summarize some of the guidance that has been codified in the American College of Rheumatology guidelines. These are the most recent from 2021. EULAR isn't that much different. And it's mainly to make the point that if we're looking for specific guidance about what drug or what mechanism of drug that we should be using for any given kind of patient, we're going to be rather disappointed. So a few things that are salient to this point, the ACR recommends a treat to target approach with strong recommendations. Okay, fine, that's definitely not picking a drug. A little bit closer to home, switching to a biologic or targeted synthetic DMARD of a different class is recommending over switching to a same one within the class for somebody not at target. So-called, treatment cycling rather than switching mechanism of action. Again, it's not what drug I should choose out of the gate, but if you're not doing well on a drug in group X or mechanism of action X, probably better to switch to Y. That's a little bit better and helpful, but still not where we want to go. And of course, is not at all informative for somebody who may be biologic naive. So some of the research that both Professor Choi and I have been part of that may be a little bit more practical that would provide some specific guidance. So in this study, the potential was examined that clinical lab or biomarker data or a combination together might help us select a drug's mechanism of action. This was specifically focused on sarilumab or adalimumab, and we both worked on this analysis, and I appreciate him putting together this elegant slide in the next one. There was a special emphasis on clinical feasibility and rule validation. So there were a number of different methods examined, but the intent was that this is going to be practical. Machine learning was used, and of course, machine learning methods are well suited for this kind of a scenario, such as we have in rheumatoid arthritis, because it can both handle a large amount of data, but it can also handle a lot of variables where you don't have to have, and frankly, you don't have foreknowledge about which are the variables that are most important and most independently important compared to other variables. And so this is an excellent machine learning problem. And so among the various methods used, the guide methodology, which is based on a decision tree type of approach, was the most successful, but there were multiple approaches even tried. Shown on the left are 42 variables, including demographics, clinical characteristics, and biomarkers that were entered, and the ACR20 response from the training endpoint using the mobility trial data was examined. On the right-hand side, there were two variables that were selected as markers of siroliumab response, both anti-CCP positivity and an elevated C-reactive protein above 12.3 milligrams per liter. And that was the rule that predicted the ACR20 response to siroliumab, and the patients that satisfied those criteria or that rule had the best ACR20 response to siroliumab. Then applying that rule to other data sets from 4 siroliumab clinical trials, looking now across a broad range of clinical scores, when this rule was applied, it does provide some guidance for clinicians looking for help in making a treatment choice. If we apply that rule to the MONARCH data, if a patient satisfied that rule, and that was 35% of MONARCH patients, the chance of her achieving an ACR70 was 5 times higher if you use siroliumab rather than adalimumab. So in other words, the response rate for that ACR70 would be enriched from 7 to 34%, about a 5-fold increase. On the other hand, for the remaining 65% of patients that were rule negative, the chances of an ACR70 response increased somewhat from 12 to 16% and were comparable with the overall unstratified population. So applying that rule could therefore help select a drug or its mechanism of action. And a practical feature of this work is that the rule was simple enough to be implemented within a clinical environment without a lot of complicated electronic tools or calculators. So changing topics, I wanted to bring you this example where machine learning and advanced analytics were used to develop an approach to automatic classification of X-ray data and outcomes in RA. As you know, there's a huge amount of time, attention, and training to read and to classify X-rays, and the complicated scoring systems and the amount of time it takes to apply them, even if you're trained, are often impediments to this being practical, certainly in a clinical setting. If you could train an automated algorithm to do that, that would certainly be of high value, because now that can be part of either the outcome for a prediction rule or even some of the features to predict response to the next drug. If you could have automatic reading and you didn't have to send it to some other center or an expert set of readers. So that might be useful not just for research and clinical trials, but also for clinical care. So a training data set was made available to train algorithms, and a separate test or leaderboard data set was then made available to allow the competing teams that were participating in this project to both test their algorithms, to refine them, and then compare the accuracy of their machine learning algorithms against others. Finally, each team's final algorithm was subjected to a validation data set to evaluate their overall performance. The results of this project showed that most of teams achieved high model accuracy. And what I found interesting is that it was actually easier for machine learning to correctly and accurately score the joint space narrowing rather than radiographic erosions. But what intrigues me even more perhaps than the actual results was that this was an industry-funded competition done in partnership, but initiated by academic medical centers and other research groups. They did something a little bit unusual that we don't often do in science. They crowdsourced the result. They offered a cash prize. Teams with expertise in machine learning were invited to compete, but you didn't have to be at an academic medical center. This approach stands in contrast to typically insular projects where one group working within a company or maybe a single academic medical center makes an algorithm, but there's not much transparency and there isn't much ability to evaluate whether that group achieved the best result and to benchmark themselves against other groups with similar methodologic expertise. And one might even think about applying an ensemble method where you could average the results across the best performing machine learning algorithms or statistical models in this kind of a pooled analytic environment. So I think that the framework in which this was done is conceptually intriguing and might herald new opportunities in the future for similar types of projects in a pre-competitive space. Let's now switch gears to something that's closer to being available to us in the clinic. The scientific underpinnings of what I'm getting ready to talk about is based in the human interactome. And by way of reminder, the human protein-protein interactome is the set of binary protein-protein interactions that has systematically undergone interrogation looking at pairwise combinations of gene products. The approach builds on the assumption that these protein interaction networks could be viewed as a map or a neighborhood. In fact, if you look at it, it looks very much like a network map that you would get out of a statistical model. In fact, you could consider a disease to be a local perturbation or an anomaly within a certain neighborhood in this map. And treatment response or non-response within that disease could therefore be conceptualized as a unique subtype of that neighborhood or a pathophenotype. So with the human interactome as background, more than 7,000 features, which is just a fancy way to say variables, including gene expression, clinical and lab results were examined and compared in RA between responders and non-responders to TNF therapy. A complex algorithm was created and then refined to both select and then model and put together the most important factors and the most important independent factors to predict TNF non-response. And the goal of this endeavor was to create a molecular signature response classifier, or an MSRC. This is a blood-based test. This doesn't require you to do a synovial biopsy like we heard about a few minutes ago. And again, the goal is to predict a non-response to TNF inhibitor. If you order the blood test and the patient has the signature of predicted non-response, what you would likely do with it is you would start with a drug that is not a TNF mechanism of action. At the point in the development of this particular classifier, it wouldn't tell you the next thing that you might want to know, which is, well, what drug should I start? It would only tell you don't start with the TNF inhibitor. You might also pause and say, wait, why are you predicting non-response? In fact, the answer is very simple, and that's because most rheumatologists in the US and Europe and probably everywhere are likely going to start with a TNF inhibitor in most biologic naive RA patients. There might be a lot of factors that play into that, but at a minimum, it could be just they were first, or that's what the rheumatologist is most comfortable with. That could be related to insurance or payer restrictions. It may just be that they don't have a good reason not to. Nevertheless, if starting with the TNF inhibitor in a biologic naive RA patient is what most rheumatologists would do, then the most practical and useful test is one that helps you make an informed choice to do something else, not simply confirm the decision you're probably going to make anyway. So let's look under the test, the hood of this test as to how it actually works. My goal isn't to make this machine learning 101, but it is useful to have a sense about how this works because it is different from traditional statistical methods. So if you look at, sorry about that, if you look at the bit on the left, so this is the single decision tree. So if you knew that a few variables were important, C-reactive protein, BMI, CCP antibody, for example, you could sort of put the most important one at the top. You could say, well, if you're CCP positive, yes, then move to the left. If you're not, move to the right, etc. The problem is when you do that, and that kind of sort of works, you don't get to have very many variables because there has to be one single most important one. And so for that reason, these tend to be overfit, meaning they may fit one data set well, but not the next one. So then you can make that even more complicated by something called random forest, which is a machine learning technique which says, well, don't go use all the variables, pick a handful randomly, build that kind of a tree with a few variables, then go randomly select a few others, build another tree, and keep doing that, dozens or even hundreds of times. And then depending upon how each tree votes, is this person likely to be a predicted responder or not based on the few variables in that tree? Make all 500 or 1,000 trees that you created vote, and whichever the majority vote is for, predicted responder or not, that's what the ultimate test result gives you. So that's essentially how random forest works. What that isn't, though, is it's not an equation that you could write down. This isn't traditional or logistic regression where you can write down a closed form solution. You're literally building a forest of trees. And then deep learning or deep neural networks or variants on that would make that set of ideas even more complicated, where multiple different variables at different levels are allowed to interact. So that's actually how this classifier works. So the 23 biologic features, 19 of them gene expression data shown in this figure, gives you a sense about how some of the pathophysiology and pathobiology in RA is represented. There are 4 clinical features, so sex, patient global, CCP antibody results, and body mass index. And together, those 23 features available in the form of a blood test are what the PRISM-RA, or the molecular signature response classifier, generates. In this first cohort that Stan Cohen published, they looked at what is the likelihood that you achieve or don't achieve an ACR 50, 70 response, that you do or don't get to low disease activity or remission by the CDAI or the DAS28. And what you see is if the molecular signature of non-response was detected, that you are 4 or 6 or even 8-fold more likely to have non-response, which is what the test, of course, is trying to predict. The N isn't huge, it's 146. And like any empiric or machine learning based method, replication is absolutely essential, because the data is telling you both what's important and it's giving you a result. So you have to test this to make sure it's generalizable and that performance stays good in other cohorts. So then let me give you another cohort. So this is the AIMS study. So this is now a bigger trial, 70 different sites looking at clinical utility conducted in the last 1 to 2 years. Very simple study design, adults with RA and all comers, irrespective of baseline disease activity. So most of these people, as you'll see in a moment, are biologic naive, although prior TNF experience was allowed. And the primary endpoint was, did the patient achieve an ACR 50 or not, as well as improvement in the CDAI greater than the minimally important difference, both at week 12 and week 24. So everybody is getting the blood test, and then we're looking ahead to see what happens. So how does this work? Again, I'm going to give you the same tree paradigm, which I think is quite easy to follow. You order the blood test, asking the question in doing so, do I start with a TNF or not? If the test comes back and the result tells you they're a predicted non-responder to TNF, you could ignore the test because you have to or you don't believe it. You could still start with the TNF, but what probably you would prefer to do is to start with a non-TNF. On the other hand, if the test comes back and says that they're not a predicted non-responder, you have the same choice, and probably you're going to start with a TNF because that's likely what you would do anyway. So again, if the outcome is the ACR 50, that's what we're most interested in. So this is the cohort's characteristics. Again, we have N's in the hundreds, but they're not gigantic. And what you see is that there are a few significant differences, age, sex, disease duration, and prednisone use between groups that either were predicted or not predicted to be non-responders, who then got a TNF or an alternative mechanism of action. But you know, those 4 variables, age, sex, disease duration, and if you're on steroids, I think those 4 things, as you would intuit, that's not going to be enough to help us pick a drug or a mechanism of action. So how did this cohort actually perform based upon what happened? So again, giving you the same paradigm. So 55% of people in this cohort were predicted non-responders based upon the classifier. The remainder obviously did not have this molecular signature. If you instead ignored the test, you started a TNF anyway, only 10% of those people got an ACR 50. But if you did what the test suggested you probably should do, start with a non-TNF mechanism of action, 35% of those people got an ACR 50 response. In contrast, if the test said, you know, you're not a non-responder to a TNF, go ahead and start with a TNF, and those people do just fine, and they do quite comparably if you start a non-TNF mechanism of action. But it's really the 2 branches or terminal nodes of this tree in red that obviously are where the importance is and where we can differentiate a drug selection based upon the test result. If you want a bit of a higher bar, you want remission. So this is the CDAI remission rates in the TNF group. If you were predicted to have a non-response to TNF, that's what the blood test told you, but you started a TNF anyway. Whereas in those that didn't have this prediction of non-response, 32% of those people were able to get into remission. So this classifier appreciably distinguishes between those able to get to remission or not based upon whether they had this molecular signature of non-response. And then finally, if you say, well, you know, I don't really measure the ACR 50 and that's a binary outcome and, you know, my world isn't binary. If you say, well, tell me what the change in CDAI at 3 or 6 months was, at 3 months, you see it's a difference in CDAI improvement of 8 versus 12 units. The bigger number means more improvement. At 6 months, that gap separates, and now it's about a 7-unit improvement, 7.8 unit improvement if you started with a TNF inhibitor, despite this person being a predicted non-responder, versus if you did what the test suggested you should do, start with an IL-6 or a abatacept or something else, where there was a 14.2 unit improvement. So, and if you look at the delta in low disease activity, the delta is about 6 or 7% as well. So if you do what the test suggests, it looks like both as a continuous measure in the CDI or binary for low disease activity, you're going to do better if you don't start with a TNF in these predicted non-responders. Overall, and across this company's development program, they sought a positive predictive value of 90%, meaning, if I do what the test says, I'm going to be right 9 times out of 10. What I find particularly intriguing is, how accurate or how high of a PPV will rheumatologists expect? If it was only 80% accurate, would that be good enough for you and I to make a treatment decision? Obviously, it's in the eye of the beholder. You can make your own decision. The sensitivity, though, is lower, 60%. To me, that's okay. If I'm going to make a decision based on the test, then to me, the most important metric here is the PPV. In fact, when they looked at a decision impact study and they looked at, well, how accurate do you have to be? That very high signature of non-response, that would be accuracy 90, 95%. You see that 89% of rheumatologists were satisfied with that. A signature that's only in the 85 to 90% range, that's high. Still a majority, 85% of rheumatologists would find that acceptable. But I think this is interesting, how good does the test have to be for you and I to act on it? And I think 85 to 90% or higher, probably the higher end of that range for me personally, 90% and above is about the sweet spot. So what do you actually get out of this? So this actually is on a continuous scale. This isn't just yes, no. There is actually something quantitative being measured. And in fact, what that maps to is the predicted probability of response or non-response. So there is quantitativeness underneath this with those biomarkers represented. And then finally, in just the last minute or two, you may say, yeah, this is great, Jeff, but will payers even care? Where I am in Birmingham in the US, mostly we have to start with a TNF, and if you appeal, you have to start with a TNF, and if you really fuss and stomp your feet and beg for something else, you mostly start with a TNF. So, but perhaps that's because we haven't had good evidence to do anything else. So this study looked at the relationship between disease activity. This is from the Corona or the Cor-Evitas Rheumatoid Arthritis Registry. We linked this to health plan data. What you see is that in that bottom table, patients in remission or low disease activity had lower rates per 100 patient years of hospitalization, ED visits, death, and had lower costs. And in fact, the difference in annual costs between those with RA in remission versus high disease activity was about $9,300. So for payer stakeholders, patients are cheaper when they have better disease control. We recently repeated this in a commercially insured population, again, with clinical data. The disease activity measure is the CDI. And so we found something very similar. Less expensive patients were those in remission or low disease activity. And then we did a subgroup analysis where, within an individual patient, if you started in moderate or high and you went to low, those patients saved about $2,000 or $3,000 in medical expenses. Unfortunately, most of them had to start an expensive drug or switch to an even more expensive drug to do that. That's the height of the red bar. So while I think that this will be cost effective, if you have to start a biologic or targeted therapy to get people into remission or LBA, it's probably not going to be cost saving. On the other hand, in the final and separate cohort using health plan data, our group was able to demonstrate that although you may spend more money in pharmacy costs, you do have an appreciable savings in medical costs. So my hope is that enabling patients to get the right drug out of the gate would be a compelling prospect, even for payer stakeholders, to let us act on the basis of tests like these if we truly can accurately predict non-response. So in the interest of time, let me just stop here and leave just a little bit of time for comments or questions. This is a summary of the things we've gone over, but very much appreciate your interest and welcome to field any things that you would want to cover.
Thank you so much, Jeff. It's really sort of a really nice fusion of thinking about the genetics and then the serological markers that we have. So we've, I think, a few seconds for some questions. But one of the things that we posited here is when we looked at this from the very beginning, it's always been lymphocyte modulators or cytokine modulators. Now we've got small molecules, targeted synthetic DMARDs. Do you think that these paradigms will shift because they're a little bit more promiscuous in terms of the sites of action, not only in the RA space, but across multiple of our inflammatory arthritis? Any thoughts on that?
Well, at least in the biologic field, the small molecule is more difficult at the onset to predict what the mode of action would be in the individual patients. I think the only way you can try to think about doing precision medicine with a small molecule is give the patient the medication and look at the response afterwards to look at how likely the patient will get better. But I was really intrigued by Jeff's presentation, because the way I kind of think of the economics of it is there is a significant healthcare cost and the medication cost associated with a non-response. So if the test can eliminate patients who do not respond, basically you save 3 months treatment with the anti-TNF, and that also has the benefit that the patient will get better. So, I don't know how much the test would be, but for me to have some certainty that the patient will respond to the treatment you prescribe is a significant advantage.
I think so clinically, although I'm not entirely certain payers will see it that way, because from their perspective, if, let's say, biosimilar adalimumab is the least expensive thing that they have to pay for, and now we're saying, well, instead you should start with abatacept or an IL-6, and under my assumption that that will be more costly for them than biosimilar adalimumab for the foreseeable future, if they're just looking at it like, I'm going to have to pay for something expensive, if all they care about is cost minimization, then maybe that argument isn't compelling, even though clinically I want it to be, and the patient is certainly better off if we get it right the first time. But I fear that if all they care about is minimizing costs, that may not sway them enough.
Yeah, the patient quality of life often becomes the least important part of those cost balance decisions. The other flip side of this is you showed that very compelling data, Jeff, that we've known about the overall changing cost of care. It'd be interesting to see how this then translates to the other outcomes. I mean, yes, we have this global sense of controlling inflammatory responses in the whole human subject will decrease many of the complications of cardiovascular outcomes and all of those things that ultimately will outstrip anything that we cost. One stay in the CCU, and you have paid for your biologic for life, right? So it'd be fascinating to see how we shift costs outside of the rheumatology space and measure the cost savings there, because unless we come in with something that's more than just, well, my patient will get better fast and will feel nicer soon, I doubt we're going to shift economists into moving to something that's already cheaper. But, this is really sort of a fascinating look as to why precision medicine matters. Yeah. And we're looking at one disease space here. We've got all the inflammatory arthritis, all the rheumatologic diseases. This is a lifetime. And I look forward to further discussions across multiple disease states with both of you on how we can change this. So I don't think we have any additional questions, but Ernest, you were saying?
Yeah, I was saying a few days ago, at the beginning of this month, I read a press release to say that we have positive result from the first IL-6 biosimilar trial. So maybe that cost minimization will be less of an argument going forward. It will be good for patient and it will be good for us.
Indeed.
Yeah, for sure. And rituximab is a biosimilar in many parts, right? So maybe that's what we should talk about, how to drive not innovators, but biosimilars, or make small molecules cheaper, who knows? But thank you so much for sharing your thoughts. And any final comments from you, just to get us off the idea of how expensive our drugs are?
The only thing that I would always make a plea for is just consider the patient's voice in treatment selection, because sometimes they don't perceive that there is a choice, or that there is a decision to be made, and whether that's based on comorbidities or multimorbidity. But I think that patients sometimes haven't been represented well in some of these trade-offs that we make in choosing a drug. But many of them, probably not all of them, but many of them actually will want to weigh in based upon mechanism of action or route of administration, things that we may put as tertiary considerations, but for them loom large. So even though we are improving the medical and the scientific aspects of drug selection, all those patient factors and their goals and values shouldn't be discounted either.
Absolutely. Oh, absolutely. I mean, we think about, I always talk about the impact not just on the person and their well-being, the fatigue, their work productivity, the fact that they now become a contributor, not a detractor to our socioeconomic productivity, but also to all of the offsets, right? The children of these patients, the family, the circle that would have been positively influenced are now carrying a heavier burden because of a single choice that we made that was based on something other than that patient's experience. So just to add to your voice on this, Jeff, I think it is critically important that we remember that people ultimately are who we care for, and the lives that they engage with. So thanks again for that fascinating discussion. And so we're brought to the close of this discussion, sadly, I must say, but really thanking the audience for being here, for joining with us on this journey. And just to let you know, you will have the option to see this again live on the YouTube sharing. So please feel free to see that. We have a short evaluation form for you to fill out at the end of this. And again, showing that the live stream version of the webinar is now available to view on the Cytokine Signaling Forum YouTube channel. So with that, thank you for your participation. And remember, in a month from now, you can join us for the next edition of Forum Live, the rationale for treatment selections in inflammatory arthritis. And that will be at the times shown here, 9 a.m. Pacific Standard Time, 12 p.m. EST, 5 p.m. BST, and 6 p.m. Central European Time. Just scan that QR code and it will take you immediately to the site to register. So thank you again for my co-host for presenting such fascinating data, for really engaging us in this kind of in-depth conversation about ultimately what matters to us as rheumatologists. And with that, thank you.
Thank you. Bye, everybody.